The first edition of my book came out in 1981.
Okay.
It's a single-authored text. This is the 6th edition that has just come out.
Wow, fantastic. And that's out now?
Yeah.
It came out at RSNA?
Yes.
Excellent, excellent. And that's the one that you've been working on with Elsevier?
Yes. That's,
Okay.
I've been working on it for the last couple of years. It's widely available. It's low cost. It is the beginning of the evaluation of almost everybody who has any kind of chest disease. Non-radiologists assume, since it's fairly simple to obtain and inexpensive, that it should be easy to interpret. But everything is superimposed on a chest x-ray. A CT scan of the chest is actually much easier to interpret than the chest x-ray. And what I have done in this book is I've identified 23 of the most common patterns of disease in the chest. And every chapter starts with an introductory case, a set of questions, followed by tables of differential diagnoses. And the tables are pretty long because there are a lot of diseases that can cause all of the 23 patterns and that I've identified as common patterns of chest disease. The real challenge for the radiologist, one is to perceive that they're abnormal, and then to describe the pattern and come up with a workable differential diagnosis. Now, a lot of the lists that I've given are very comprehensive, and you would like to really be able to narrow that down. And I've broken it down by categories of disease. Is it most likely an infection, or is it most likely a tumor, or is it most likely something developmental? And then you can begin to correlate the clinical setting of the patient and the clinical information that's available and figure out a pathway for working up the patient to come to a diagnosis. But you can rarely move from a chest x-ray to a diagnosis. You've got to really go through a sequence of evaluating the patient's history, his physical findings, what's the appropriate workup of the patient. Will CT answer the question? Frequently the CT will answer the question. Often the CT better shows the pattern, better shows the distribution of the disease, makes it easier to evaluate, but you're still left with the same differential diagnosis. So you may need a biopsy, for example, to make a diagnosis. I think it's beyond a medical student.
Right.
I think it probably is a little bit beyond the first few months of residency. I think it really is more directed toward a review near the end of residency to kind of consolidate what they've been learning during the residency. And I think it's a handy reference for the practicing radiologist who needs to go back and look up something or review something in a succinct way. Like I say, it's a single volume text. It's readable. You can sit down and read the whole thing. Where some of the competing texts are multi-volume text, and there really are truly references. More than one publisher, it's been through a series of mergers, basically. I've never changed, but it's been passed along from one publisher to the other. And I have to say, working with Elsevier has been a very good experience. I have had the best editorial assistants this time that I've ever had. Now, that doesn't mean that when we read it, we may not find a grammar error or a typo somewhere that they didn't catch or I didn't catch. I'm not blaming them. They actually did catch a number of those things that are really a problem for a single author because you've got the whole thing. If you had a committee of people starting it, they can kind of filter out a lot of the things. But I've got the total responsibility for the whole book. So always worry about inaccuracies. The big issue is we still want to make a diagnosis. And the RSNA this year is talking about personalized care. And we really need to figure out a way to get from having non-specific findings to specific findings. And a lot of the exciting advances in chest radiology are really CT. And when CT first came out, we knew it had a lot of potential, but we had no idea. And I can remember people in the 90s saying that CT was a mature technology. Things that we can do now are just quite remarkable. I mean, we routinely do coronal and sagittal reconstructions. And by doing those reconstructions, we get a much better idea about the distribution of disease. As I mentioned, some of the things in the chest x-ray are superimposed. And for example, diffuse interstitial lung disease, if you have honeycombing fibrosis, it can look fairly uniform and diffuse on the chest x-ray, and when you do the CT, you realize that it really does have a peripheral distribution that basically wraps around the lung, predominantly involves the basis of the lung. So you get a lot more information from CT. And CT has been an ongoing revolution in chest radiology. MR has lagged a little bit because we've had problems imaging the lungs with MR. But MR is superb for the mediastinum, the vessels. We've seen a lot of courses here at the RSNA where we're looking at the aorta with either CT or MR, and some of that's in the book.